Hi, this is Elliot Fishman, and welcome to our latest talk on the role of IV contrast and scan protocols in the oncology patient. What do we need to know? It's interesting, we have many lectures about IV contrast, we have many lectures about protocols, but we typically don't focus only on the oncology patient. So what I would like to do in this talk is look specifically at the oncology patient. That is the oncology patient different than the regular patient? Well, if you think about oncology, what are we doing? Whether it's chest or abdomen, musculoskeletal, neuro, detection and definition of the presence of tumor. We want to stage the tumor correctly, and based on our staging and based on our findings, subsequent management decisions, whether it's surgery or chemotherapy or radiation therapy or some combination, will be done. We also will use CT for follow-up post-therapy, restaging. Is the patient getting better or getting worse? And we'll also use CT for complications. Pneumonia, abscess, enteritis are just a couple of those complications. Now, when you think about the delivery of contrast and the importance of protocols, think about this hepatoma, hypervascular lesion, right lobe of the liver, non-cirrhotic patient, pseudocapsule. The neovascularity is best captured on the MIP imaging. The cinematic rendering shows the pseudocapsule very nicely, the difference in texture between the tumor and the normal liver. Or in this case, in a patient who's cirrhotic and there's a 2.5 centimeter mass, right lobe of liver near the caudate lobe, it's a bit subtle on the axial imaging and a bit easier to see on the MIP. You recognize delivery of contrast is critical. If this patient had delayed phase imaging or poor injection, you would not pick up this 2.5 centimeter mass. We know the same thing is true in pancreatic cancer. Adenocarcinomas, typically hypodense. We'll use CT to define vascular involvement, whether it's on the arterial or venous side. We'll look at SMA and celiac and hepatic artery and portal vein and SMV. We'll look at the liver, in this case an accessory right hepatic artery. And then, of course, in that same patient, the occlusion of the splenic vein with multiple collaterals. Now, splenic vein occlusion alone does not make you unresectable. Portal vein involvement with the SMV for a distance will make you unresectable. We look at renal mass as hypervascular mass, obviously a renal cell carcinoma, but with the central necrosis and hypervascularity, we know it's a clear cell renal cell carcinoma, and recent articles suggest with central necrosis, these patients will do poorly. The neovascularity of tumor very nicely shown on the MIP imaging. The washout showing as we go from hyper to relatively hypovascular mass. And again, the various appearances with cinematic. We are exploring what cinematic can provide. So when you think about it, how well we detect a tumor, how a tumor looks, how much information we can get out of a study is totally dependent on delivery of contrast. And then as we get down to AI and radiomics, it's even equally or makes it more important. So what decisions we make, the type of contrast, the volume, the injection rate, and the acquisition phases. So you can ask the question, is the oncology patient different than non-oncology patients, or is it all the same? Are there specific risk factors in the oncology patient? Is it related to tumor type? The fact that patients more likely are going to get multiple exams? Sometimes because of chemotherapy, the patient could be hypotensive. Patients may have cirrhosis, like the patient with hepatoma. Patients are often dehydrated. They may have tumor spread, like peritoneal carcinomatosis. All of these things in select articles have shown to be of concern. So, questions maybe we don't think about. When do you do a contrast scan? Do you do it after chemotherapy or before chemotherapy? Do you wait 24 hours or does it make a difference, or you need to wait 48 hours? Is there an increased risk in the oncology patient in general with IV contrast? And if so, how do we minimize the risk in the oncology patient? We talk about timing. Do complications of IV contrast incur in any specific relationship to this timing? We do many patients, and I'm sure you do as well. A patient comes to CT, gets a scan, then goes to the clinic and may get chemotherapy in the afternoon. Is that the way to do it, or should the patients come a different day, and should you spread the studies apart? I know it's inconvenient, but what's the safest thing to do? Should we design protocols that combine clinical information with scheduling of the study? Is there a best time to do the study? These are all very good questions. Now, there have been a number of articles, and what I'm going to share with you is the literature for about 12 years. And so you can see where things are changing and where we're thinking differently. This article by Jay, he was in Mallinckrodt at that time, he's now up in Mayo. The risk of contrast-induced nephropathy in cancer patients may be compounded by advanced age, dehydration, and administration of nephrotoxic chemotherapy drugs. Thus, identification of patients who are at risk for SIN is important in order to avoid potential serious complications. Potential options for patients at risk for SIN include alternative studies that don't require IV contrast, hydration pre- and post-study, and the reduction of contrast volumes. Jay is also very clear to say patients at risk for SIN should not be denied a CT scan with contrast if the benefit of the study outweighs the potential risk of the study. And that's something we always know. Everything is a risk-reward. As long as the study gives you critical information, it's typically worth the risk. An article a couple years later by NG, Effective IV Contrast Medium on Renal Function in Oncology Patients. Administration of IV contrast in oncology ICU patients with normal creatinine is associated with an increase in creatinine levels, but not beyond those simply undergoing CT of a matched non-CT group in the ICU. The EGFR, which includes sex and its derivation, may be a better predictor of contrast-enhanced renal function than creatinine. And just to make the point now, all of us are using GFR. He goes on to say that among oncology patients in the ICU with normal creatinine levels, administering IV contrast is associated with a rise in creatinine levels, but not beyond that of simply undergoing CT. So again, he was saying it was safe even in patients who are in the ICU. This article by Prehydration, the incidence of contrast-induced nephropathy in patients with myeloma is low and correlates with beta-2 microglobulin levels. Now, this is an article that looks at a specific disease. So I put this one in there because myeloma is one of the diseases where people get very worried. Some people are always scared about giving contrast in myeloma. Patients with myeloma, make sure you hydrate them, but if they have good renal function, there's no increased risk, as this article makes the point. One of the challenges, of course, a lot of what we look at is saying oncology patients without looking at specific drugs. But specific drugs will be a challenge. We often don't know the risks, and patients are often on multiple drugs. So again, we tend to be general rather than very specific in most cases. But again, in the future, they may not be true. Background: cancer patients undergoing CT scans with iodinated contrast media. It is not known whether a time-dependent correlation exists between chemotherapy, contrast-enhanced scans, and the onset of adverse events. And their conclusion, looking at 10,472 contrast-enhanced scans, was our results did not reveal any correlation between time to CT and risk of acute related events in cancer patients. They went on to say around 1% of oncology patients receiving treatment may develop acute contrast-related renal insufficiency. However, there was no good demonstration of a very good time relationship. So again, that becomes a very important thing. So you don't really need to think about that per se when the two things are together. In this article by Chan et al., there is little published evidence examining the use of contrast media and the risk of adverse events in patients with increasingly common risk factors, including cancer and chronic renal disease. So their study was to test the hypothesis that in patients with cancer, having CT with contrast would have a higher rate of contrast-induced complications. And they looked at 29 million inpatient visits across 611 hospitals. That's some kind of data. Patients with chronic kidney disease having a CT with iodinated contrast have a risk of up to 9.7%, depending on the stage of kidney disease. For patients with cancer, the risk increases, but less than 2%. So there's a small increase in risk, but very small. The conclusion was that in patients with cancer at a higher likelihood of developing acute renal adverse events, but it's a small percentage. And again, hydration, lowering contrast volumes, isoosmolar contrast agents all make things better. So again, becoming very, very important. Again, look at those numbers. Risk increase from baseline by type of cancer range from 0.3 to 2%. It also makes the point, this article, that the risk will be dependent on your primary tumor. Again, we don't typically model that into our work, but I think AI can be very valuable in modeling both the patient's creatinine levels, the GFR, when chemotherapy was given, as well as the type of primary tumor. Perhaps we need to look at all of those various features. So that indeed becomes a very important way of thinking about things. In this other article by Seek In Hong, they look carefully to measure the incidence and identify potential predictors of contrast nephropathy in cancer patients without kidney disease and with normal or near normal baseline serum creatinine levels. And they found the incidence of contrast-induced nephropathy was 8%. They had certain things that gave higher risk: hypotension, cirrhosis, peritoneal carcinomatosis were all independent features. Even when the baseline serum creatinine is under 1.5, a significant portion of cancer patients are still at risk. And again, they mention these findings. So it's good to think about them. No doubt any patient who's hypotensive is at increased risk. Cirrhosis, often patients with cirrhosis have renal disease, so there is some relationship there. Dehydration is always going to be a problem, so we need to hydrate. And peritoneal carcinomatosis is something I've never considered, and we'll have to keep looking if that indeed is the case. A couple years later, and just recently, COSME, the risk of developing kidney insufficiency are increased in elderly, in patients with chronic kidney disease and diabetes, and with certain nephrotoxic chemotherapies. Okay, so one of the things they mention is that primary care physicians and specialists who deal with cancer patients should be aware and be importantly aware of potential strategies to minimize this potential risk. And they looked in this article by COSME, they looked at high-risk features, medium-risk features, and low-risk features. And again, they looked at things ranging from timing of contrast delivery to what drugs the patients were on. The more drugs, the worse it was. The closer the interval since chemotherapy, the worse it was. The larger the volume of contrast. But of course, 250 ml, we do CT for no more than 100. So this really relates to angio more than CT. But again, everything is kind of thrown together. And again, they go through some of the different strategies of what you can do depending on high, medium, or low risk. But again, looking at those charts, you could see hydration, isoosmolar contrast, lower volumes, and again, with things like dual energy, we could lower the volume. We all know you need a certain volume of iodine to pick up liver metastasis. That never changes, but obviously, things like 250 cc's are not something we do within CT. So some of the strategies they came up with: prehydration, tailored dose of contrast. Again, don't give more than you need, but give enough. Saline prehydration. Lowest osmolarity contrast is ideal. Isoosmolar should be considered the first choice in this setting, particularly if patients with cancer present a high risk for developing kidney disease, such as those with diabetes and liver disease and hypertension, older patients, and patients with cardiac disease. So again, isoosmolar agents can be very valuable. Isoosmolar contrast media should be considered the first choice in this setting, particularly if patients with cancer present a higher risk for developing acute kidney injury. So again, when you start looking at contrast should be selected based on patient risk. Same article, They made the point about prehydration, contrast, and again, understanding what needs to be done in that individual patient. Another key point to keep in mind is that beyond cisplatin, a number of other anti-cancer agents may induce glomerular injury as well as interstitial nephritis. So again, as we mentioned, there are so many different chemotherapies. They behave a certain way alone. They behave a certain way when you have multiple chemotherapies. And these days, patients often get combination chemotherapies, so it is something that can be a challenge. Some numbers: the incidence of kidney injury in patients with cancer between 12 and 17%, and it's higher than patients without cancer. So you can see 4 to 11% difference. Risk factors include the type of cancer, comorbidities, and other drugs being used. Specific cancer locations and cancer types also have been linked with acute kidney injury. Again, I think this is something we need to learn and we will need to adjust in the future. Among commonly used anti-cancer agents, an increased risk has been documented in certain agents. You can see cisplatin is one of them. And a short time span between chemotherapy and contrast is associated with an increased risk. So again, going back to the same thing: hydration, spread the timing between contrast and chemotherapy if possible. If it's not possible, like rule out PE, you need to do the study when it needs to be done. And again, understand which specific agents the patients are getting. An article by Lachi: cancer patients at GFR below 59 were associated with increased rate of kidney injury independent of contrast exposure. Congestive heart failure and prior kidney injury were also associated with increased rate of AKI. So again, just some more information and things you need to think about. And in their regression analysis, you can see some of the numbers for the various things. And again, obviously, risk becomes higher as your GFR decreases. Same article. This is the largest retrospective study to date that has examined the rate of kidney injury after non-contrast and contrast scans in a cancer cohort at a cancer center. Administration of contrast was associated when patients would get kidney injury with lower GFRs at baseline, independent of exposure. So that's probably not going to be surprising. And you can see some of the other risk factors very much like other articles. Low incidence of kidney injury suggests that a reduced dose of an isoosmolar contrast agent is safe in high-risk oncology patients. So again, you can see all of the articles. This one by Werner does make the point about the importance of isoosmolar agents. So again, cancer patients are higher risk patients. So when we look at resources and we look at safety, it's a good point for using isoosmolar agents. Now that basically is really what I wanted to speak to you about: contrast and what we can do to minimize the impact on the oncology patient. But as long as we're talking, let me mention a few more things. Other issues: vascular access, frequency of extravasation, and higher injection rates. We need high injection rates when we're doing CT angiography. This article by Silva made the point: the incidence of contrast extravasation in cancer patients was no different than the general population. The key thing, of course, is being careful, knowing how to start IVs, and selecting the right IV for the patient. The incidence of contrast extravasation was similar to the general population. The majority of extravasation cases were mild, and no severe cases were observed in the study sample. So that is indeed good news. When you look at what causes contrast extravasation, you always think about high contrast rates or high contrast volumes, but it's really the needle and the placement of the needle. The extravasation rate was highest with 22 gauge needles. When you have 20 or 18, you have less extravasation if it's placed correctly. Also, if you put needles in the hand, particularly with fast injection rates, even though the veins look good, particularly in older patients and oncology patients, the extravasation rates were significantly higher. Also, it's no surprise because of vessel fragility, older patients are more likely to have extravasation. I also recommend warming the contrast. There have been several articles showing that when you warm the contrast, many of the side effects, even the mild feeling warm or taste, disappear. But also when you warm contrast, there's less issues with extravasation. There was an article from Duke that said you had 3 times more extravasations, same population, if you did not warm the contrast. Warm the contrast. It's really easy. 37 degrees, get a warmer. So concluding then, we know how important CT is in oncology, from tumor detection to staging to management to follow-up to looking for complications. But when you use contrast, think about the fact that these patients are at higher risk. Choose the best imaging study. If CT is the study of choice, great. Optimize the protocol. Minimize the volume of contrast to the correct amount. Don't give any extra. Pre-warm the contrast. Hydrate the patient, if necessary, pre- and post-study. Minimize the risk to the patient by using isoosmolar agents. And again, I think we need to really be thinking about a comprehensive plan to help prevent or minimize any complications. And with that, I thank you for your attention.
If you liked what you heard here today, please make sure to hit that subscribe button and visit our website CTisus.com for lectures, quizzes, pearls, and more. Also, be sure to check out our apps that are available for free on the Apple Store. All links are in the description box below.